Thank you very much and good morning everyone. The PEPTIC Trial is a trial of proton pump inhibitors versus histamine receptor blockers for stress ulcer prophylaxis in the intensive care unit. And it's the hardest trial that I've ever done. I started off doing this trial in Australia and New Zealand, and it would have failed if it wasn't for the fact that friends from the Northern Hemisphere, from Ireland and Canada and the United Kingdom came to the party and saved the trial. As I say, there were many times when this trial was happening that I thought that finishing it would be impossible. And so for me, the most important thing that I learnt from this trial is that the difference between possible and impossible is hard work every day and the passage of time. So, the PEPTIC trial has been simultaneously published with this presentation online in JAMA. And before I talk more about it, I would like to acknowledge the fantastic work of the members of the management committee. In particular, I would like to acknowledge the project managers in the respective countries, Leanne, who oversaw the whole trial and did a tremendous amount of work, and Daisy and Dawn and Kathy in particular. I also would like to acknowledge and I guess express gratitude for the people who reviewed the paper and provided fantastic feedback, for the editorial stewardship from JAMA, from Howard and from Derek, who greatly improved the balance in the manuscript, I think, from what I submitted. And also to Emily Greenhow, who's the manuscript editor from JAMA, who helped me tweak the words, which I think matter, and I hope that in addition to listening to what I have to say, that you'll all read the paper, because frankly I'm very proud of how it's turned out. So enough self-congratulation. So I know what you're thinking. How can anyone be excited by stress ulcer prophylaxis? Surely this must be the most boring thing in the history of the world. And I have to say that I have some sympathy with that position. And more than anything, the thing that I'm excited by with this trial, although there is, I hope you'll agree, practice-changing results in relation to stress ulcer prophylaxis, but it's the methodology. So we enrolled 26,982 patients from 50 intensive care units in 5 countries for a budget of under $500,000 US. So the PEPTIC trial is now the largest trial, randomized clinical trial ever conducted in the field of intensive care medicine. But before I tell you about the methodology, I'm going to have to tell you something about stress ulcer prophylaxis and why we did the trial. So stress ulcer prophylaxis is administered to patients very commonly. In fact, the vast majority of mechanically ventilated patients in current practice receive stress ulcer prophylaxis, and they do it because they receive it because the clinicians want to stop them from having upper GI bleeds. And there is considerable variation in terms of what's used. So in some intensive care units, proton pump inhibitors are used, that's in the majority. In other intensive care units, histamine receptor blockers are used, and actually that variation is largely to do with doctors and hospitals rather than to do with patients. And so one reason for choosing proton pump inhibitors potentially is that we know that they reduce clinically important upper GI bleeding. The relative risk for upper GI bleeding in the SUP ICU trial with proton pump inhibitors compared to placebo is 0.58, so they're actually quite effective at reducing upper GI bleeding. But on the other hand, there's this concern that the more profound acid suppression you administer, the more you increase the pH of the gastric juices, you promote bacterial overgrowth, you get then reflux of bacteria, which can get down into your lungs and cause pneumonia. It also turns out that proton pump inhibitors have immunosuppressive effects, so they suppress natural killer cell function, they impair the oxidative burst response of neutrophils, and the clinical importance of those immunosuppressive effects are sort of unknown, but there's not really any doubt that patients who are critically unwell might be particularly prone to the adverse consequences of such immunosuppressive effects. One particular concern is that the use of proton pump inhibitors might increase the risk of C. diff, which has been recently renamed, just for those who thought I didn't know what it was called. And, you know, importantly, despite the fact we've been giving stress ulcer prophylaxis drugs for decades, and there's this idiosyncratic practice variation that exists, the effect of these respective drug classes on mortality is unknown because adequately powered clinical trials comparing these drugs have not been conducted. Now, clearly, any mortality effect attributable to the choice of stress ulcer prophylaxis in intensive care patients is small. But these drugs are given to millions and millions of people around the world, and so if you say there are 2.5 million ventilated patients, ventilated in emergencies and intensive care units in the developed world alone, a 1 percentage point difference in mortality would account for 25,000 lives lost or saved if we're giving the wrong drug. And year after year, you don't have to take very many years for that to add up to quite a large number of patients. So the PEPTIC trial is an international open-label cluster crossover randomized trial comparing histamine receptor blockers and proton pump inhibitors. Now, the cluster crossover design is an interesting thing that's worth talking a little bit about. So in a cluster trial, you randomise, rather than randomising individual patients, you randomise an intensive care unit. And in randomising an intensive care unit and a group of patients over a period of time, you reduce precision compared to if you conduct an individual patient randomised trial. The reason that you do that is that over a period of time, within an intensive care unit, mortality rates will vary. Yeah? And so that introduces noise, and as I say, it reduces precision. In a cluster crossover trial, each intensive care unit will do one treatment, and then they'll do the opposite treatment. That means that the noise that you introduce by the clustering effects is cancelled out by the fact that each intensive care unit contributes to both treatments. And if the amount of noise is precisely the same in both treatment periods, then the noise cancels each other out, and you end up with similar power to if you conduct an individual patient randomised trial. Now, because we didn't know what the noise would be, we used existing data sources to estimate the amount of power that we would have in our trial, and we designed a trial which had 80% power to detect an absolute difference in mortality of 2.4 percentage points. Now, the idea there essentially is that effectively if we see no difference, that means that we'll have 95% confidence intervals that are under 1.5 percentage points and potentially getting close to a minimally clinically important mortality difference. As it turned out, we vastly underestimated the amount of power that we would have. So the amount of noise in the two treatment groups balanced itself out very, very well, And essentially, we ended up with a very similar amount of power to this, as this had been an individual patient randomised trial. So we ended up with 80% power to detect a 2.2% absolute mortality difference. Sorry, 80% power to detect a 1.8 percentage point mortality difference, and 90% power to detect a 2.2% mortality difference. So that means that if we had observed no effect, we would expect the 95% confidence intervals to exclude the possibility of mortality increasing or decreasing by 1 percentage point. So potentially, for the first time in a randomised controlled trial in intensive care, we have power to detect perhaps the smallest difference that might matter. So there you go, 80% power 1.8, 90% power 2.2. So we randomised entire intensive care units. We had 50 intensive care units, and 25 of them used proton pump inhibitors as their default stress ulcer prophylaxis for 6 months, and then histamine receptor blockers for the subsequent 6 months. And another 25 used histamine receptor blockers for 6 months and then proton pump inhibitors for 6 months. And it turned out that the characteristics of these intensive care units that were randomised into these two sequences of treatment were very similar. So in order to conduct this trial with a relatively small amount of money, we used a combination of registry and trial-specific data sources. So if there were existing data that we could use in a registry, we used those data. So the mortality data, the ICU admission source data, the basic demographic data, all came from existing registries. Looking at upper GI bleeding rates, these were collected using trial-specific data sources, and clostridial infections were similarly generally collected using trial-specific data sources. So all the patients who were mechanically ventilated within 24 hours of admission to the intensive care unit were included in the trial, except for those patients who were admitted to the intensive care unit with a diagnosis of upper GI bleeding. We had 50 intensive care units that were randomised. As I said, 25 were allocated to each sequence, and they implemented the treatments. We had 12,273 patients who were allocated to the PPI H2RB sequence, and 17,018 patients who were allocated to the HRB PPI sequence. So if you look through at these things, you can see there we have patients from the PPI HRB sequence who end up on PPI in the bottom right-hand corner there, and we'll carry on down. There was a very small number of patients who opted out of study participation, a small number of patients where mortality data were missing from the registry. And once you get down here, we combine the data like this, and you end up with 13,415 PPI group patients and 13,356 histamine receptor blocker group patients. So these were pretty typical intensive care patients, or pretty typical sick intensive care patients anyway. So the average age was 58 years, 2/3 are male, 50% medical, 50% surgical, a third elective admissions. Apache 2 score was around 19, and as you'd expect with a massive trial like this, the baseline characteristics are extremely well matched by treatment group. I would now like to go through, and I want to tell you 10 points about the study treatments. So the first point is that we implemented these treatments at the level of the intensive care unit rather than at the level of the individual patient. And so what this means is that this is best thought of as a trial that compares two stress ulcer prophylaxis strategies implemented at the level of the intensive care unit. And I will talk more about that later. The study treatments were open label. we would have needed like about $10 million to do this blinded. So that was a practical decision, and even open label was complicated. So there were times during the conduct of this trial where we were facing an international ranitidine shortage, and we had to defer sites starting because partly actually because in Australia the amount of ranitidine that we were using for the trial was actually contributing to the shortage. Clinicians decide which patients need stress ulcer prophylaxis, and so only the patients who were considered to require stress ulcer prophylaxis by the treating clinician received it. And as it turned out, that then ended up being over 90% of all of the patients who were included. The default stress ulcer prophylaxis was that was allocated to the intensive care unit. So if a patient was in the intensive care unit when the intensive care unit was allocated to histamine receptor blocker, then the default prescription for stress ulcer prophylaxis would be that drug. Patients who were taking PPIs prior to admission to the intensive care unit, they would switch to the histamine receptor blockers if the ICU was allocated to histamine receptor blockers, unless the treating clinician felt that was an inappropriate thing for that patient. And then the patient could continue on PPI. Patients who remained in the intensive care unit through a crossover period continued with the treatment they were originally assigned. And there was no washout between treatment periods. So we essentially had a day where we said, okay, all the new patients who come into the intensive care unit from now on, they'll be on the next treatment. The treatment duration was until the patient was discharged from the intensive care unit, until they died, or until the treating clinician didn't consider that stress ulcer prophylaxis was indicated anymore. And really importantly, the clinician could override the default. So if, for whatever reason, the treating clinician believed that a particular patient would benefit from receiving one treatment or the other, they were allowed to use that treatment. If upper GI bleeding occurred, then the patients, irrespective of what was assigned to the intensive care unit, would change at the discretion of the treating clinician to a PPI in treatment dose. So in the trial, we didn't collect stress ulcer prophylaxis use at an individual patient level for every patient. So what we did varied from place to place, but for some places we had monthly audits where we would look at what stress ulcer prophylaxis was being used in mechanically ventilated patients for once a month, and that was supplemented with electronic prescribing data where it was available and pharmacy dispensing data where that was available. There are some intensive care units we have all of the data of every drug that was received, but that's and what was received by individual patients, but that's a minority. So this is a figure that you can find in the supplement of the paper. And it doesn't all fit on one slide, so it actually goes over the next 3 slides. What this figure is an estimation of the treatments that were received by the patients by intensive care unit. So the box on the right, as you look up at the screen there, is the ICUs that were randomised to a sequence of PPI and then histamine receptor blocker. And on the other side is the ones that were randomised to histamine receptor blocker, then PPI. Each silhouette on this slide represents 25 patients. The red silhouettes are patients who received proton pump inhibitors. The blue silhouettes are patients who received histamine receptor blockers. The grey silhouettes are patients who didn't receive any form of stress ulcer prophylaxis. And the pink silhouettes, of which there are none on this particular slide, are patients who received both the histamine receptor blocker and a proton pump inhibitor. Okay. So the numbers that you can see there are the randomisation order. And as we move through to the next slide, you can see that there are a number of patients on this slide that received both. The reason that accounts for the majority of these patients actually is that these are intensive care units. We had data on every single drug that was prescribed during the entire intensive care stay. And so the vast majority of these pink patients are patients who received one dose of a PPI when they were admitted to the intensive care unit, and then the next morning they were changed over to the default stress ulcer prophylaxis for the intensive care unit. And that's right through to our 50 intensive care units. And so this is a sort of summary of the exposure to different drugs. So in the PPI group, 82.5% of patients received a PPI. But actually in the histamine receptor blocker group, about 20% of patients received a PPI. So while there is very substantially different exposure between drugs, this is different from an individual patient randomized trial, and that does complicate the interpretation of the trial somewhat. But in fact, perhaps not as much as you might think, at least that's what I believe. So the primary outcome variable was in-hospital mortality during index hospitalisation up to day 90 from the date of the index ICU admission. And I've been particularly pleased by the general tone of the meeting because it's really relevant to this study. One of the things that turns out to happen when you have a very large sample size is that the p-values that you generate vary quite dramatically depending on the statistical method that you use for your analysis. So we conducted 20 sensitivity analyses using different statistical methods for cluster crossover trials, and the primary endpoint varies depending on the method used, from a p-value of 0.03 to a p-value of 0.10. Now, one of the other things that happens with a very large data set is that the confidence intervals do not vary. So the lower limit for the 95% confidence interval is 0.99 to 1.00. And in fact, for the vast majority of the analyses, the lower limit of the confidence interval is 0.999 to 1.001. Okay? So the notion that the p-value, which varies in an arbitrary way depending on which statistical test that you use, matters when the confidence intervals range from 0.999 to 1.001 is particularly ridiculous. So with a big sample, with a large number of events, you have very narrow confidence intervals. And in the PEPTIC trial, we have more than 5,000 events. So 18.3% of the PPI group died, and 17.5% of the histamine receptor blocker group died. The relative risk by point estimate is 1.05. The 95% confidence intervals are 1.00 to 1.10. The 99% confidence intervals are 0.98 to 1.11. And the 99.9% confidence intervals are 0.97 to 1.13. And so, to my way of thinking, the data are consistent with an effect size that ranges between no effect and an increase in mortality with PPIs. Now, just to confuse everyone, including myself, here is the point that with all of these different methods of statistical analysis, none of which I understand, the risk ratios are essentially identical, although, as I've already said, the p-values vary. We can express this in terms of an absolute risk difference. So the absolute risk difference is 0.93, 95% confidence intervals, 99% confidence intervals, and 99.9% confidence intervals. So the chances that proton pump inhibitors reduce your mortality by more than 1 percentage point has to be astronomically low. But the possibility that they increase mortality overall, I believe, is genuinely real. So if this point estimate was true, then for the 2.5 million ventilated patients in the developed world alone, this is 23,250 lives that we can save by not using proton pump inhibitors for these patients anymore. This is the survival plot, showing the separation, as you'd expect, I guess, occurs relatively early. Now, a key secondary endpoint is overt upper gastrointestinal bleeding. We used the same definition as was used in the sub-ICU trial, so you had to have overt bleeding plus a drop in haemoglobin or initiation or increase in vasopressors, decrease in haemoglobin, or a transfusion of at least 2 units of red cells. And 1.3% versus 1.8% of patients had GI bleeds. This is a lower event rate than in the sub-ICU trial, but that reflects the fact that this is not a high-risk cohort. This is just everyone who was ventilated. And this is a highly statistically significant finding. So the risk ratio is 0.73. The 95% confidence intervals you can see there. This is highly statistically significant even when it's adjusted for multiplicity, and it's consistent with the existing literature. And overall, I think, on the balance of what we know, it's reasonable to say that these drugs do what they're supposed to do. There's no suggestion that PPIs increase the risk of clostridial infections. Relative risk there embraces the null, and by point estimate, the risk was lower in the PPI group. The ICU length of stay was numerically slightly longer in the PPI group, but statistically not different. And we analysed this as a time to event analysis, which is why it's presented as a discharge rate ratio. So that's the confidence intervals you can see there. Again, the hospital length of stay is numerically a little bit longer in the PPI group. In both of these analyses, we accounted for the competing risk of death in an appropriate fashion. This is the duration of mechanical ventilation. Again, this is expressed as an extubation rate ratio. And this is interesting, actually, because in this particular analysis, the proportional hazards assumption's not met. So what that means is that over time, the extubation rate is not uniform. So this is an average rate of extubation, but for the patients who stayed in the intensive care unit for a long time, those patients who were allocated to a PPI were less likely to be extubated in the next little while. We didn't measure pneumonia in all of the patients in this trial because we couldn't really collect the data, but for a nested cohort of patients from the Canadian sites, we measured this ventilator-associated conditions, which is essentially a deterioration in a previously stable mechanically ventilated patient, and it's sort of a surrogate measure for pneumonia. And the risk ratio here was consistent with an increase in the rates of ventilator-associated conditions with patients allocated to proton pump inhibitors. We had a number of pre-specified subgroups. I'm not going to talk about all of those, but I'm going to talk about the cardiac surgical patients because I think this group is important. So there were greater than 6,500 cardiac surgical patients in this trial, and clinically significant upper GI bleeding was really rare. It only occurred in 0.7% of patients in either group. And yet the risk ratio for death with PPIs, as you can imagine, the mortality rate in cardiac surgical patients was really, really low. So in absolute terms, this was a small increase, but the relative risk of death was greater for the PPI group. Now that could be a statistical anomaly, but given that GI bleeding is really rare in this group of patients, there seems to be little to lose from changing from PPI to histamine receptor blockers. And then finally, in response to reviewers, we conducted an analysis looking at the effect of illness severity. So in the SUP-ICU trial, one of the surprising findings was that patients who had very high illness acuity had a higher risk of death if they were allocated to PPIs. And so we sort of had a look at this, and this is not so sick to super sick, quartiles of a PEPTIC 2 score, and the relative risk of death with PPIs compared to histamine receptor blockers. Everything above 1 is an increased risk of death. And so what you can see on this graph is the point estimates from each quartile and the 95% confidence intervals. For the upper quartiles, those with the highest risk of death, there is an increase in the risk of death for patients allocated to PPIs. As you can see, for the third quartile, that's actually quite a long way away from 1, so that is a highly statistically significant finding. Now it drops down again for the super sick patients, but you have to remember that we didn't exclude patients in this trial who were anticipated to die. So some of the very, very sick patients in this trial had very likely, some of them would have been brain dead at the time they were admitted to the intensive care unit, and they still would have been eligible. Clearly they weren't going to be saved by a histamine receptor blocker. So I want to thank again the members of the management committee, all the coordinating centres, the investigators and sites, the patients, their families, and I'm very much looking forward to the discussion. While Morton's doing his editorial, I'm going to be posting what I think the trial results mean on Twitter. Thank you.
Thank you, Paul. I'd now like to invite Morten Müller from Copenhagen to deliver an editorial. Thank you, Morten.
Yeah, thank you very much. Okay, thank you very much. So first of all, thank you for a nice talk, Paul. Looking forward. First of all, I think we should say thank you very much to the Critical Care Reviews meeting, to the organizing committee for arranging this fantastic meeting, getting an opportunity to discuss trials, interpret trials, so that's unique, I think. Second, also congratulations to everybody involved in the PEPTIC trial. It is indeed a huge accomplishment and a very, very important trial with clinical important implications. Okay, I have no direct conflicts of interest, though I have some indirect conflicts of interest. I'm a clinical researcher and I do research on this topic as well. So you need to take that into account. First of all, I think PEPTIC trial is a fantastic, high-quality, modern trial, and also recruitment was extremely fast. It holds several strengths. First of all, I think it's a really clinically important question. So in critically ill patients in the ICU, should we give PPIs or should we give H2 blockers? Second, there was a pre-planned and published protocol and statistical analysis plan, and it was very comprehensive. Also, it was mainly patient-important outcomes that were included, and in fact, I was very happy to learn that the primary outcome was actually changed during the trial in order to make it even more patient-important. Second, follow-up was fantastic. Almost 100% of follow-up for all outcomes. Impressive. Results were very consistent as outlined by Paul. So sensitivity analysis and subgroup analysis mainly supported the primary finding. It was a brilliant pragmatic trial, simple inclusion criteria and simple exclusion criteria. And as Paul has already alluded to, it was a very realistic effect size, a 2.4% absolute risk reduction is definitely a realistic effect size. Also, the sample size was enormous. In fact, existing data on PPIs versus H2 blockers amounts to close to 8,000 patients. So this is 3 or 4 times the existing number of patients randomized to this. Internal validity was in general high, I think. And obviously the design was very elegant. Cluster crossover registry embedded randomized clinical trial. There are obviously also some things to look out for, some caveats, or at least some things that we can discuss. First of all, as alluded to by Paul, it was an open-label trial. So obviously there is a risk of performance bias. So clinicians may behave differently and give drugs differently to different patients. Second, exposure to treatment was actually below 3 days. So the a priori chance to get separation between the two groups may not be very big. And then I think that you can discuss both the quality and the validity of registry data. We already discussed this a bit yesterday with the sepsis study, and I think that results need to be interpreted in light of this, as also outlined by Paul. And again, Paul touched upon this. The trial had a power of 80%, meaning that there is, in fact, a risk of a type 2 error, so a false negative finding of 20%. But I just learned from Paul that, in fact, this was much smaller because it was overpowered. Also, in general, external validity was indeed high. So 50 sites and 50 countries. But you need to interpret your results in context of the department that you come from. So mean age was below 60 years. That's slightly lower, at least than where I practice. 1/3 of the patients were elective surgical patients, and also the majority of patients were included in Australia and New Zealand. Finally, I think it's fair to say that there was a bit of heterogeneity with the intervention. So different drugs were used, different dosages, and also different ways of administering the drugs. Okay, we also need to talk about the elephant in the room, obviously, and Paul has already alluded to this. Crossover, and by crossover, I don't mean the randomized and planned crossover, but more the unplanned crossover in this trial. As alluded to by Paul, in the PPI group, 30,000, close to 500 patients were randomized. The majority had the intervention, so PPI. However, 4% had H2 blockers, 1.9% had both PPIs and H2 blockers, and some 11.5% did not have either of them. Correspondingly, in the H2 blocker group, also close to 14,000 patients, only 63% received the intervention H2 blockers, whereas 20% received PPIs, 11% did not receive any, and 5% received both. So this will definitely dilute the results and introduce bias, but it's really difficult to say both the magnitude and also the direction of bias, and it likely varies from outcome to outcome. Okay, yesterday we talked a bit about the fragility index, and I would like to use that on the PEPTIC trial. So how robust are the results? Well, looking at clinically important GI bleeding, where there was a statistically significant difference, the fragility index is 27. So of note, in general, in critical care trials, the fragility index is usually between 0 and 2. So just changing the statistical test will swap the results from a statistically significant result to a non-statistically significant result. So again, I think it's really fair to say that results are very robust, as outlined by Paul. Okay, what if we compare it to existing evidence? Just recently, a systematic review or network meta-analysis was published. So looking at mortality in PEPTIC, the point estimate was 1.05 with the confidence interval going from 1 to 1.10. In the network meta-analysis, the risk estimate and the credibility interval was 1.11 with the credibility interval going from 0.89 to 1.35. Importantly, only 5 trials had high quality of evidence in the network meta-analysis. So that's why the 95 confidence interval is much wider. For clinically important GI bleeding, results are somewhat consistent, a point estimate of 0.73 in PEPTIC and 0.58 with a wider confidence interval again in the network meta-analysis. For pneumonia, and as Paul alluded to, pneumonia was not per se registered in PEPTIC, but ventilator-associated complications were registered. The point estimate was 1.18, and in the network meta-analysis with the 5 trials, it was 1.11, so quite similar, I would say. For C. diff infection, also quite similar, 0.74 versus 0.88 in the network meta-analysis. So it appears that results are quite consistent with existing evidence. So what should we do? What should we do in clinical practice if we decide to give acid suppressants or stress ulcer prophylaxis? Should we give PPIs or should we prefer H2 blockers? Well, I think we need to do some simple math or some simple calculations. These are the estimates from PEPTIC, so 18.3% risk of mortality in the PPI group versus 17.5% in the H2 blocker group, and so forth, and VAE is ventilator-associated events. So looking at the absolute risk reduction here, for mortality it's 0.8%, for clinically important bleeding it's 0.5%, for ventilator-associated events or complications it's 0.7%, and for C. diff infection it's 0.13%, so a really, really low absolute risk reduction. This corresponds to the following number needed to treat and number needed to harms. So you would need to give H2 blockers to 125 patients in order to prevent 1 episode of GI bleeding as compared to giving PPIs. You would need to treat 200 patients with PPI as compared to H2 blockers in order to prevent 1 episode of GI bleeding. Correspondingly, you would need to treat 143 patients with H2 blockers in order to prevent one episode of ventilator-associated complications, and you would need to treat 769 patients with PPIs in order to prevent 1 episode of C. diff infections. So number needed to treat or number needed to harm are quite high. Okay, so where do we stand? So if we prefer to give PPIs, I think we need to acknowledge that there is a possible increased risk of pneumonia or mortality. On the other hand, there is somewhat higher certainty that the risk of bleeding is reduced. On the other hand, if you prefer giving H2 blockers, there is likely a decreased risk of pneumonia and mortality, and correspondingly an increased risk of GI bleeding. So what do we do? Well, first of all, I think we need to include patients and ask patients what they prefer. So we need to get some patient feedback on this. What matters most to patients? This has been done recently, trying to give guidelines or guidance for clinical practice. In this clinical practice guideline, they compared different ways of administering acid suppressant, and the recommendation was that in critically ill patients who are going to receive prophylaxis against GI bleeding, we suggest giving a proton pump inhibitor. However, a H2 blocker is also a reasonable choice. So a weak recommendation in favor of giving PPIs. Okay, another thing I would like to touch upon, and which was also touched upon by Paul, is the effect modification of disease severity. So, as alluded to by Paul, this was a post hoc analysis, subgroup analysis, so it could very well be a chance finding. That's important to state. However, there was an indication of increased mortality in patients with higher disease severity receiving PPIs. So is this a unique finding? No, not really. As shown by Paul, also in the sub-ICU trial, this was found. In PEPTIC, disease severity was expressed by Apache 2. In the sub-ICU trial, it was expressed as SAPS-2, but same finding, suggested increased risk of death in patients with high disease severity, randomized to PPI. But again, it could definitely be a chance finding. We looked more into this, again in a post hoc study, where we looked exclusively at patients with high disease severity, so patients with a SAPS-2 score above 53. And we found the same finding as illustrated here with time to survival with PPI versus placebo. Recently, a Bayesian analysis of the stress ulcer prophylaxis, of the sub-ICU trial, was published, and actually the same finding was present here. So it seemed that with higher disease severity, there was a suggested increased risk of death in patients randomized to PPI. So is there at all a biological rationale, or is this plausible? Well, it could be, I think, because with increased disease severity, you may have more organ failures, and with more organ failures, you may be more susceptible to both side effects of PPIs and also drug-to-drug interactions. So there may be a plausible or biological rationale for this. So does that mean we need to pull the red handle and don't give PPIs to patients with high disease severity? I'm not sure about this, but I definitely think that we need to look more into this in the future. So there remain some unanswered questions, although PEPTIC have provided important data on this topic. First of all, again, we need to look more into high versus low disease severity in patients randomized to PPI. So the large collaborative trial in Canada and Australia and New Zealand, the revised trial, hopefully they will be able to at least stratify according to disease severity, or maybe make inclusion criteria according to this. Second, we also need more data in children, and luckily there is a nice Canadian pilot trial which are being wrapped up at the moment called PICkup trial. Also, we need to look more into the effect of enteral nutrition. Can we use enteral nutrition instead of acid suppressant, or does it modify the effect? Second, in the PEPTIC trial, it was pragmatic, as I said, with simple inclusion criteria, so it was mechanically ventilated patients, but there are also other risk factors for GI bleeding, and some may be even more important than mechanical ventilation. Also, we need to look at long-term outcomes and preferably quality of life. And also costs need to be considered, and I was very pleased to see your cost estimate in your presentation with $400,000, right, for running PEPTIC. So that's definitely a large difference according to a conventional randomized trial. So in summary, I would like to congratulate Paul and everybody involved in the PEPTIC trial. It's an amazing trial. It has significant clinical implication, and importantly, I think this stresses that we definitely need pragmatic trials. Thank you.
Morten, thank you very much. Paul, is there anything that you would like to reply to just now immediately following that editorial?
So, I mean, I really agree with everything that Morten's said in relation to his, to the commentary there. One thing that I think is really important to remember, and for me, my view of the implication of this trial has changed dramatically since I first saw the results. I think that given that these are drugs that are already being used, then changing your practice is a really appropriate thing to do based on an assessment of the balance of probabilities, not based on certainty. And so I have a really quite strong view that the majority of people would, you know, if you said, I'm weighing up the possibility that a drug might kill you, I don't know for sure, but it might, and on average we have to treat 200 people with this drug in order to reduce the chances, in order to stop one from having a clinically important upper GI bleed that almost certainly won't kill them, that people would say, well, what's the problem? You know, like, and so I think while people will weigh up an uncertain increase, this possibility of an increased risk of death against an unequivocal reduction in GI bleeding differently, clinicians, ultimately to come down on the side of giving a PPI as the default in the face of the possibility that you might actually be killing 1 in every 100 people just makes no sense to me. Thank you very much.
Thanks, Paul. So, thank you. So, you know, let's be fluid. Morton, I think you've got
just a short comment. I tend to agree with you, Paul. So, and importantly, if a patient gets a GI bleeding, what is the treatment? The treatment is giving a PPI, and the corresponding number needed to treat for therapeutic treatment is 10 to 15. So you only have to treat therapeutically with PPI. If you have a patient with GI bleeding, you only have to treat 10 or 15 patients to treat the bleeding as compared to 200 if you give it prophylactically.
Thanks, Morton. Okay. So I'd just like to pick up, Paul, the issue around the geographical spread of the trial. You've mentioned that this was a highly efficient trial from a cost perspective, but I'm sure different nations contributed in ways that might not have been explicit. So, for instance, in the UK, the NIHR would have had deeply embedded infrastructure that assisted this, and probably isn't obvious. So what we're really interested in, were there any geographical differences? So when my trainees come and work with you in Wellington, you know, are they going to have the same experience when they come back to Manchester?
Yeah, so there's different ways of confronting that, I guess. So the word geographical differences in the way that we collected information, and I think actually they are borne out in the trial results. So in relation to the GI bleeding risk, there was statistically significant heterogeneity based on geographic region, and Canada was different from everywhere else.
Okay.
And I think it's almost certain that the reason for that is that in Canada, the GI bleeding rate, clinically important GI bleeding was measured using an algorithm that extracted words that were associated with overt GI bleeding from the electronic health record. And so that's a really sensitive way of detecting this overt GI bleeding. You know, if anywhere in the clinical record someone writes coffee grounds, then that comes out and turns into a GI bleeding rate.
Yep.
And so the GI bleeding rate in the Canadian patients was higher, and the effect size that was evident in the Canadian patients was less, which I think is because most likely in the Canadian trial, in the Canadian group of patients, it was the method of detection GI bleeding was very sensitive, but it wasn't very specific, so there's more noise.
Yeah. So that's a really helpful answer, thank you. So I'm going to invite colleagues from the audience to raise questions. Is there anybody that would like to ask a question at this point? We have a colleague here. If you'd like to introduce yourself.
Thanks very much, Nick Timey from Portsmouth. So to speak sort of crudely about it, it seems that the PPIs stopped patients from having GI bleeds but they killed them by another means. From looking at the evidence of respiratory problems, it doesn't seem to be through increased VAPs. Do you have I know it's not really from the results of the study, but do you have a sense of what the mechanism of the PPIs killing people would be?
So I don't think we can say that it's not from VAP, actually. I mean, the ventilator-associated complications point estimate is a relative risk of 1.18, which is an 18% increase in the rate of ventilator-associated complications. That's an entirely plausible effect size, and it could well account for it. You know, I guess when I presented the introduction, I talked about those immunosuppressive effects, and one of the really important follow-up exploratory analyses that we have planned is to look at the patients who are admitted to the intensive care unit with an infection-related diagnosis, because if this is an immunosuppressive effect, then one would imagine that the risk of death would be more manifest in the patients who are admitted to the intensive care unit with an infection. We haven't done those analyses yet, but we certainly plan to do them. And you know, there are people who are out there who will say, look, the mortality's higher, but this is probably a chance finding, and you haven't encountered for a mechanism for it, and therefore I don't believe it. And I'm fine with people who believe that. They're wrong, but I'm fine with it. You know, this is not a situation where this is a new drug, where the level of evidence needs to be overwhelming. For people who want to refute the results of this trial, which now is the operative truth, they have to conduct a trial. That's what I think.
Morten, did you want to say something there?
Yeah, and importantly, it's used off-label in the ICU, so it's not registered for use in the ICU. Other potential mechanisms could be increased risk of myocardial ischemia. The difference may also be low, but it could be. And also in other populations, acute kidney injury has been suggested.
Thanks very much. I think the trial's very convincing.
Any other questions from Howard? Just behind the editor of JAMA, just behind you.
Paul, quibbling with you around critical care medicine makes me a bit anxious, but I will quibble. This study didn't assign individual patients to PPIs or H2 blockers. It assigned entire critical care units.
Yep.
And there is a very substantial difference between those, as manifest that 30 or 35% of the patients in one group didn't get the assigned drug. So I think one needs to be careful about distinguishing between mandating individual patients getting H2 blockers versus PPIs, or a preference within an intensive care unit to use H2 blockers, allowing clinicians to opt out when they believe something else is indicated. I have great trust in clinicians. And I'm just wondering if you agree that there's a distinction between these two issues. You tested a strategy, not actual assignment of individual drugs.
Thank you, Howard.
Yep, so absolutely. So, you know, that message comes across very strongly in the written paper, and the crossover certainly, you know, I knew it would come up and we would discuss it. It certainly adds complexity to it. There are two different ways of thinking about it, right? So the people who were assigned to histamine receptor blockers, who received proton pump inhibitors, all things being equal, that should bias against us finding a difference, right? So that should actually reduce the effect size. The only situation in which it wouldn't decrease the effect size is if the clinicians who were giving the patients in the histamine receptor blocker group PPIs were correctly selecting a subgroup of patients who had a lower risk of death with PPIs. So if they were correctly selecting patients who had a lower risk of death with PPIs, then that would reduce the mortality rate in the histamine receptor blocker group, and it would increase the separation between treatment groups. My own personal bias is that when you weigh up those two possibilities, I think it's far less likely that the clinicians were correctly selecting the patients who would have a lower risk of death with PPIs in some selective way. I think that the reasons that people were getting the wrong treatment actually were more likely most of the time to be random. And while it does increase the amount of uncertainty about the estimate between groups, I still think on balance it's likely that this is a real mortality effect that's buried in here, which is hidden to a degree by the crossover. Now, that isn't to say that the way to think about this is no patient should ever receive a proton pump inhibitor for stress ulcer prophylaxis again, because there are real uncertainties. You know, the people who arrived in the intensive care unit taking a PPI already, that might well be a group of patients where the clinicians were less likely to stop those patients and switch them over to a histamine receptor blocker. And genuinely, I don't know what we should do with those patients. But I do worry about the notion of the clinicians taking the message away, well, as long as I just choose whatever I want for the patient in front of me, if I think they should have a PPI, nothing bad will ever happen. I think that's scary territory, particularly because when you look at the highest risk patients who conventional dogma would have said are the most likely to benefit from PPIs, they are the ones who died in the PPI group.
Thank you, Paul. Could I just briefly, Matt, come to the Twitter feed? Any themes that are coming up?
Yeah, so there's a few different questions. Firstly, Paul, a couple of questions looking at the exposure time to PPI and whether that was associated with an increased risk of death, and kind of linked into that current practice in a lot of intensive care units is once enteral nutrition is established, PPIs and other gastro prophylaxis is usually stopped. Is there a sense of an association with that as well?
Yeah, so a couple of points. So one is, it's important to remember in this trial that we studied essentially an all-comers mechanically ventilated in the first 24 hours in intensive care unit population. And so there are a number of patients who had a short exposure to stress ulcer prophylaxis. You know, like there's a lot of elective surgical patients who came to the intensive care unit for a day. Yep, they had a low exposure. But the patients who had the highest risk of death, where the greatest separation between groups occurred, they stayed in the intensive care unit for longer, and they had more exposure to the treatment. Now, you can't really look at the relationship between length of exposure to treatment and outcomes, because length of exposure to treatment is a post-randomization variable, and it might well have been affected by treatment assignment. So as soon as you try to make a comparison and say, for the patients who stayed in the intensive care unit longer than 10 days, what was the story? You're no longer conducting a randomized comparison.
Okay, one final question, Matt.
Just one other practical question. Looking at the cardiac surgical patients who present, who are already established on PPIs in the community, what are the implications for continuing those drugs once they're admitted to ICU, which is probably current practice at the moment? If you're on a PPI, you stay on a PPI.
Yeah, what to do with that particular situation, I don't know the answer. I don't know the answer.
Thank you. So we're going to move on now. We've got a fabulous panel on stage. I want to get them involved methodologically, practice considerations. Just really briefly, Francois, do you want to introduce yourself? People will know you already, but just 15 seconds.
Francois Lamontagne, I'm an intensivist working in Canada.
Kathy.
I'm Kathy Rowan, I'm Director of the ICNOT Clinical Trials
Hugh
Unit.
Morton, we've heard from.
I'm sorry?
We've heard from Morton.
Oh.
Marion Campbell, a statistician with an interest in cluster trials.
Thanks. And Chris.
And Chris Nixon, I'm an intensivist at the Alfred, and I probably prescribe a lot of PPIs.
So Chris, I want to come to you first, actually, because so about the interpretation of this. We'll come back to some of the methodological issues, particularly around databases, etc. But sort of drawn to the notion of practice of evidence-based medicine. So Sackett said it's about, the evidence, it's about our priors, and also we want to hear from patients, and Morton mentioned this. So how are we going to progress this debate? Howard's made a very important point that this is at a unit level, not at an individual patient level. So that whole complexity here with high-quality evidence, how are we going to move this into practice?
Well, I agree with the comments that we've always got to consider the patient in front of us, but I'm actually pretty aligned with Paul, I think, in that you start off with the default strategy and then you can tweak it from there. And I think based on this, my default strategy is going to change. And that finding about the cardiac surgery patients, all of our cardiac surgery patients get PPIs. None of them ever have a GI bleed that I've seen. And that's a group that I think I'll definitely be anxious about, because it's just such a ubiquitous thing that we do. Every single patient gets this drug, and it's not. I guess I realise I've probably been coasting through the years, kind of thinking that these drugs are kind of equivalent. But when you picture it in terms of the sheer number of patients worldwide who receive these drugs, that's where the impact becomes real. So I think my personal view, I think we're going to have to do a lot of education and discussion when we go back to our individual units. Also discussing with lots of other teams, because these medications often continue after the ICU and for various reasons, and people have reasons why they want certain drugs to continue. So I think it's absolutely fascinating study. I never thought I'd be this fascinated by stress ulcer prophylaxis. And Paul's come a long way since I carried him through medical school back in Wellington. So I think a lot of education, we need to go back and have a discussion. I think great point by Howard that, we are clinicians. We've still got to think about patients at the bedside. But for me, I think the default strategy probably has to shift.
What about the severity issue, which seems to come through and alter this balance of risk?
It's a thing, because it's an easy thing to say, well, I'll just reserve PPIs to the high-risk patients high risk of GI bleeding, but do we really know who those patients are? Okay, maybe if you've got someone on aspirin, clopidogrel, they got coags through the roof and you're about to thrombolize them, I'll give them a PPI, but we just don't really know what those groups are, I don't think, which makes it tricky. And that's the dilemma of a clinician. We have uncertain evidence that we have to weight in probabilities but be decisive at the bedside.
So can I just make a response to that? So one of the unique things about the PEPTIC trial is we now have an absolutely gigantic data set in which to explore some of these preconceived notions about the patients who might particularly benefit from stress ulcer prophylaxis. And questions like, if the patient has coagulopathy, well, elements of coagulopathy are captured in the registry data that we have. So we can look at people who've got low platelet counts, and we can look at people who've been admitted with diagnoses of bleeding, and we can see in what will amount to many thousands of patients what it looks like the balance of risk is. Now, these are all going to be exploratory analyses, but they're going to be exploratory analyses with many thousands of patients that are going to, I think, greatly enrich our understanding of the risks and benefits of these different drugs for different patient groups.
Paul, is there any way, because Morton brought up the acute kidney injury, and I think there's usually a couple of times a year where I see a patient who's got eosinophilia and kidney function sort of going off, and that's when I cross off the PPI. Is there any way that you can explore maybe that as a contributor to mortality?
I think that will be a challenge. I think that will be a challenge.
Okay, so are we going to get the Wellington score coming soon? Or? Francois, I'll come back to you, Kathy. Francois, I think you had a comment.
Yeah, so congratulations. I think it's a beautiful, beautiful study and accomplishment, and I'm rather impressed and convinced, in spite of the remaining risk that perhaps the crossover might have bias, as you said. But I also sort of think it's unlikely, and if anything, the open label is the other sort of quote-unquote limitation. But I think looking at how often, like the direction of the crossovers, if anything, a priori bias was in the other direction. So I'm still sort of rather convinced by the mortality differences. The one thing that strikes me, for me, the elephant in the room is that clearly it seems that there's a disconnect between the effect of PPIs on bleeding and mortality. That's an interesting finding, and it's not inconsistent with previous evidence. And yet, at least where I'm from, and I assume in many other places, PPIs became a standard of care, right? I mean, were used a lot, and presumably, I haven't reviewed the historical literature, but even the fact that that we sort of missed this perhaps and sort of makes me question the utility and the need of gastroprophylaxis at all, because presumably we started adopting anything, H2 blockers, and because of the bleeding risk. And those early studies probably did not have the power, and so is giving. And now that others have alluded to the effect of different nutritional therapies now, maybe, and haven't seen a lot of GI bleed as opposed to when I first started, and so I think we probably struggle with the recognition that there's a lot of uncertainty about what we do in general. And while your results might, convince me that between two evils, there might be one lesser evil, in keeping with my general bias that, less may be more, and that we're perhaps not recognizing the harm that we do, I think it opens up a huge question now of saying, given that disconnect, and given that we can't really rely on GI bleed to determine whether we should treat those patients. Maybe it's just the prophylaxis itself that's the problem.
So I have a few comments. So one, and it's not in the paper, but if you look at the number of patients who both had a GI bleed and died, the number of patients who both had a GI bleed and died is higher in the histamine receptor blocker group. Okay, so I think it's highly likely that proton pump inhibitors both reduce gastrointestinal bleeding and reduce the risk of dying from gastrointestinal bleeding. But I think it's also highly likely that that effect is outweighed by an adverse effect that results in increased mortality rate with PPIs. Now, the question as to whether or not stress ulcer prophylaxis is indicated at all, well, that question is now clearly much more important in light of the PEPTIC study findings. But I wouldn't underestimate the importance of upper GI bleeding, because actually upper GI bleeding is, it's quite likely it causes anxiety for families, it causes anxiety for patients, it causes difficulty for clinicians in terms of decisions that they make about whether they do an upper GI scope, what they do with the patient's aspirin, what they do with the anticoagulation. And actually, all of these things, they're not insubstantial issues. It is quite likely that if you stop stress ulcer prophylaxis altogether, that you will encounter GI bleeding in 3 or 4% of all of the patients that you're looking after. And then instead of just going and having coffee breaks, you'll have to stress out about whether you need an upper GI scope. And so that is actually a relevant consideration, I think.
Yeah, thank you, Paul. It's a very balanced.
Oh, and actually, I forgot to answer the question before about nutrition. And so I will come back to that. So, you know, I think we do have the opportunity to explore the relevance of that by looking at subgroups of patients who are less likely to be fed based on baseline characteristics, like general surgical patients and so on. But actually, you know, the evidence that supports the notion that gastrointestinal bleeding risk is modified by whether or not you're receiving enteral nutrition is extremely weak. It's really just dogma. And I think that, you know, in Australian and New Zealand intensive care units, everyone gets fed immediately. And so, you know, I don't actually think there's likely to be a lot of patients there who aren't being fed.
So I mean, we've got a little bit of time left. There are some very important methodological issues that we'd like to cover, both with Marion and Kath on databases and embedding trials into established audit systems. And Marion, I'd like to come to you first around the cluster design here, because clearly you're a real expert in this. Paul presented something that seemed very cogent. I just wondered if you have any comments about the design here.
Yeah, absolutely. And I think what Paul has shown here is how a cluster trial can really, you know, enable, I mean, it's obviously a large trial because it was a cluster trial, but it enabled something to work in practice and to work quickly. And I guess it added another complexity by having a crossover in the cluster. And this is, you know, something that's happening at the minute. It's, you know, it's a very happening design. And so I think we're learning a lot by being able to offset quite a lot of the extra patients you need in a cluster trial by doing this crossover, and then you gain the power back. And I suppose I was just going to ask Paul if he could maybe talk a little bit, particularly I think about this crossover time point, because you mentioned you had no washouts. So I was thinking, how did you manage this? So did you have, you know, the patients who were on PPIs coming in, and then they crossed over to the blockers scenario? How did you manage the patients?
So
and how was their outcome
the patients who were
assigned?
already assigned to a treatment, they continued on the treatment that they'd been assigned.
Okay.
And then the new patients who came in from that day forward were assigned to the next treatment. So essentially there's like a work up to the crossover period where there's kind of an education campaign, and you say, as of blah-de-blah date, we're going to be changing from this to the next, and then the research nurses have a period over a few days where they're very intensively scrutinising the charts and making sure people are doing what they want to do. But one real advantage of a whole of ICU trial like this is that people get used to the intervention pretty quickly because they're doing it to everybody. And so, you know, I mean, I think there are a number of lessons about the design, and I think, you know, although we managed to do it on a very small amount of money, one of the lessons for me is actually you would be well advised to spend more money so that you can spend more on educating the staff and monitoring the compliance with, you know, assigned treatment more closely. You know, because the crossover would clearly be much better and easier to interpret the trial if the crossover was lower or the non-adherence was lower.
Well, the other thing I was just going to ask you was, you know, obviously, you know, we've learned a lot about how to manage cluster trials, and they're now pretty routine, so they're not the scary thing they were in the past about how to do it. In fact, I was actually stunned you had 10 methods of doing the analysis. That was beyond scary. I guess, why did you have 10? I mean, surely there was one that was the primary method anyway.
Yeah, so the primary method is what's reported, and the p-value is 0.054 for the primary method. But you know, I mean, the choice of primary method can be debated, and so that's the thing that I find particularly interesting. You know, is how that choice is actually, we stuck with what we said we would do, but the choice about what we said we would do was to a degree arbitrary.
Did you look at
Oh, yeah. So, introduce yourself.
William McBride from Belfast, a local boy. Did you look at the sedation regimens that the patients were on in the different groups? Because obviously stress ulcer prophylaxis is the end of the sequence, when stress is probably what is triggering the problem in the first place. And some intensive care units would titrate to a given RAS, some don't give any sedation at all, some more. And if you looked at different subgroups in your study, in your trial, of those who were perhaps not sedated, would that be the group in which you would get greater differences, perhaps? Have you any subgroup analysis on that? Thank you.
Yeah, we don't have those data. And I guess all I can say is in this trial, we let clinicians give stress ulcer prophylaxis to the patients that they believed required stress ulcer prophylaxis. And that turned out to be 90-something% of the patients, 92%, I think, of the patients. We will be looking at various subgroups where, people have believed that the risk of stress ulcers is greater, and trying to get a sense of how the balance of risk and benefit plays out across those different subgroups, but that's work that we haven't undertaken yet.
Thanks, Willie. Marion, can I just come back to the power of the study? Because you've taught us, certainly in the UK, about the importance of the number of clusters rather than the number of people that are recruited to the trial. And I wondered if you'd want to make a comment on that and the choice of 50, how crossover affects that, just to remind us all.
So I think the important thing about a cluster trial is the more units you have in the study, the better the power. So, I think you had you had 50 ICUs from across 5 countries. And that's almost, the way we would want cluster trials to be run. Large number of units, which then minimises the intra-cluster correlation coefficient, to get techie, but basically the clustering effect. And the crossover element then adds a level of methodological rigour to it that then, maximises the benefit of this. So if you've got an intervention that you can do a crossover, and certainly in the sort of prophylaxis sphere, that would be a good thing to do, then you really maximise very quickly the power of this mass data set that you've got. And so I think, the idea of having this sort of evaluation of a management strategy of prophylaxis is the way to go if we're thinking about evaluating this type of intervention, because you will get scale, you'll get power, you'll also get, as you were mentioning, you'll be able to manage the noise in the different arms of the trial, from the intervention to the balance. So I think it's really the way to go, and it's great to see something as good as what's been done in PEPTIC. That's just the model for how to go forward from here.
So one important point to make in relation to the crossover, I said when I did my presentation that if you're lucky, the noise gets cancelled out, because essentially the comparisons occur within an intensive care unit and then they're pooled. Now, as it happened, the noise almost cancelled itself out completely, so that if you look at the data set and you calculate the primary outcome variable just using a Fisher's test, you basically get the same answer as if you calculate it using gigantic inverted matrices that take a computer a whole week to calculate the p-value. But there's no guarantee that that would happen next time. So we were very lucky in the PEPTIC trial, I think, that these noises cancelled each other out so well. And one of the things that worries me a little bit about the cluster crossover design is the uncertainty about how that noise will pan out in different groups of patients and how it will pan out in future, and the effect that it will have on the power. Because actually, the difference in power that we had between what we planned to have and what we actually had is astronomical. Like 80% power to detect 2.4% versus 80% power to detect 1.8% is a very, very big difference. And it turned out to be really important, because actually, if we'd only had the power that we'd anticipated we would have, we would have been underpowered.
So we've got a few minutes left, and I definitely want to come to Kath about embedded data sets. But Morton, what are the challenges around these different trial designs to meta-analyze? Because clearly these are important data to be considered now as part of the BMJ activity, so in partnership with JAMA. So what are your thoughts about that?
Well, I definitely think that the existing recent systematic review needs to be updated. I think we need to include the PEPTIC data, even though they are somewhat different and not randomized on the individual level. I think definitely they need to be taken into account.
Yeah.
And then subsequently we need to look at clinical practice guidelines, obviously.
I mean, one of the things I think is really interesting is, obviously I read that BMJ paper, and the point estimates from that BMJ paper basically they're the same.
Yeah.
As the PEPTIC trial.
Morton.
And so the PEPTIC, the BMJ paper says, there's no suggestion of a mortality effect. And actually, the reality is that the 12,000 patient meta-analysis is underpowered.
Yeah, indeed.
Because the effect size suggested by the point estimate could well be the effect.
Yeah.
And clearly, that effect would be clinically important. I mean, it's impossible to argue that that's not a clinically important effect for global public health. And so the conclusion is wrong. The conclusion should be that the confidence intervals encompass the possibility of clinically significant harm.
So we look forward to the updated meta-analysis. Kathy, can I come to you, please? Because there are crucially important methodological issues here, and Paul's alluded to some about how data is collected and the internal validity of that. We're obviously at the NRCHR very obsessed with efficient trial design, utilising the fabulous kind of resources that are available at ICNARC. Any comments about how this went for you, your views about use of embedded trials? We heard about 65 yesterday. Over to you.
Thank you. Congratulations, Paul. And I'd like to shout out for Daisy Wiley at the ICNARC Clinical Trials Unit, who ran it from our end, and to the 15 UK sites and the people who worked hard to help us deliver it. I'd also like us to be under no illusion that it was really, really easy and it only cost £500 or whatever it was. So I think there's a lot of hidden costs, and I think we should be really, really explicit about ultimately what it truly cost, if that makes sense. So I'm now interested in, I think there's an important discussion around the design of the trial, and we've talked about cluster and cluster crossover. I think there's a lot to be learned from the conduct of the trial and how little we know. So you're starting to ask the kind of questions that you'd ask in an individual patient data randomized trial, where we'd know about the co-interventions, we'd know about the sequencing. I think the adherence data, so Daisy's a great trial manager, and she would feed back, we'd chat sometimes during the trial. And if a unit was originally a unit that used H2 receptors, they sort of behaved differently when they crossed over to PPI and vice versa. Some of that is shown in the adherence, but not necessarily all of it, and I'd like to understand that better. So they found it much harder to be a usual PPI site to go to the H2 receptor than vice versa. But then you've got actually non-adherence in all those sites, so that might be subtly different depending on what you were as an original site. So I think there's something in that. I probably should have been more aware of the reason for the GI bleeding in Canada and that kind of differential effect of how we capture our data. We've got to understand that better, because that might be going on in other elements of the trial, and I think we need to know a little bit more about that. I worry about the short-term outcome. I may be the only one who worries about the short-term outcome, but it was hospital outcome. We do have some longer-term outcome in some of the places. Maybe we might want to look at that too. I think nobody's talked about, certainly in the UK, whenever we do a trial, we have to do obviously an evaluation of the clinical effective, but also an evaluation of the cost effectiveness. Given the way everybody's been talking here, I assume these things cost exactly the same price, so we're not actually talking about
they cost almost nothing.
Money. So that's sort of I think another important element to sort of state there. But I just feel that even on the adherence in UK sites, it was snapshots. And so we don't really know what they were doing, and then it was applied snapshots. I just think we need to unpick what the data has driven, how the data were captured, what the data has driven in the results of this trial, so that we understand that in terms of taking it through to the next trial. And it may well be that we need to be, there's some combination of how much detailed data you do collect on top of, obviously, the data-enabled, efficient design, registry-based, and then understanding that our different registries kind of do different things and measure things. We know that serious adverse event reporting in trials is notoriously difficult, and if you're kind of relying on a registry for it, I'm not actually sure that adverse event reporting might be as standardized as we like. So there's something in all of that. So we've got the statistical design, the methodology, brilliant. Then we've got the kind of the gritty-gritty of the sort of conduct that we really ought to explore.
Kathy, thank you very much. Paul, I'm not going to allow you to come back on that, and I'm sure we'll continue discussion either on Twitter or in the room. So I'm going to draw this session to a conclusion and thank all the members of the panel, Paul, Morton for the editorial, and Jama for Howard being in the room as well, which is fabulous. Please go and get a coffee, go and say hello to the exhibitors.